friends. I am so happy you're here. Happy Halloween. Today we are here getting a bonus session. We usually just do the first and third Thursdays, but this was a fifth and it's Halloween, so it's extra special. Just like my guest speaker tonight is Dr. Daniel Grove, and he is a gem of a person to have put up with me for an evening and signed up for this talk. I think he knew that he wasn't going to get away without signing up for a talk. And Dr. Grove is a board certified derm and pediatric dermatologist. He finished up his derm residency and peds derm fellowship at a great institution, Indiana University. And after he completed his training, he joined the Akron Children's Hospital as the staff PD derm, and he does a vascular lesions clinic, inpatient consult service, surgical management of pigmented and vascular lesions, and he's an active teacher as well in peds and derm. So again, he's now in Charleston, South Carolina, and he has just really had some great experiences. So I am so excited for Dr. Grove to be sharing with us as our guest speaker, because I know I'm going to learn a lot, and so are you. So you want to take it away, Dr. Grove?
I will. Thanks so much, Dr. Gree. So I have the lofty task of introducing you all to vascular malformations. Over the next 35 minutes, hopefully, we'll simplify things for you. I always found this topic confusing when I was a dermatology resident, even first off into my pediatric dermatology fellowship. I have no relevant financial disclosures, no conflicts of interest, and I will be talking about some off-label use of medicines, especially when it comes to overgrowth syndromes and vascular malformations. So the goals for today is I want you to walk away having a refreshed knowledge of vascular malformation nomenclature. We'll review some of the common presentations and kind of broaden your clinical acumen when these patients walk into your clinic. We'll review some of the basic overgrowth syndromes. That's a topic in itself that takes an entire lecture, but we will broach those. And then we'll also review updated vascular malformation management. So what are vascular anomalies? So a vascular anomaly is a very broad umbrella term. We use this colloquially. Typically, when we're addressing vascular anomalies, we're not specifically mentioning a diagnosis. If we're talking about vascular anomalies, we're breaking them down and we're talking about either vascular tumors or vascular malformations. Vascular tumors are de novo lesions that are either benign, borderline, or malignant growths that have their very own unique behaviors and growth patterns. I think you all have had a lecture previously about infantile hemangiomas, and that's a classic example of a vascular tumor, as opposed to vascular malformations, which are congenital lesions. These are lesions that present due to postzygotic mutations, and they usually have a sole driver vessel, for example, like a simple lymphatic malformation or a simple venous malformation. And their growth pattern, unlike tumors, grows with patients. We don't talk about cures when we treat vascular malformations. We just talk about medical management, either through surgery or medications. This is further examples breaking down the nomenclature of vascular tumors and vascular malformations. Vascular tumors is a mixed bag. It's sometimes tough to remember all of them. These are things like infantile hemangiomas or congenital hemangiomas and their subtypes like rapidly involuting, non-involuting, and partially involuting, as well as more rare lesions like tufted angiomas or spindle cell hemangiomas or things like caposiform hemangioendotheliomas. Vascular malformations, you can kind of lump them together conceptually. You have a mutation in a primary vessel that's causing these vessels to overgrow and grow with the patients. So as patients grow and they're going through puberty and the rest of the body's growing, these vascular malformations are growing with them. And that's usually when they present. They'll present to your clinic with a new swelling or a new lump that hurts or something that may be cosmetically bothering them. So we break them down into simple vascular malformations, meaning just one vessel involved, such as lymphatic or venous or capillary or arteriovenous AVMs. Due to the genetic etiology and overlap with how these vessels develop, commonly patients will have more than one vessel involved. So they might present with a combined vascular malformation, such as a lymphatic and venous. And then in addition to vascular malformations when patients present, we often do a full skin exam, mainly looking for signs of overgrowth. This can be things like tissue hypertrophy or skeletal changes like leg length discrepancy. When you have a vascular malformation and anatomical anomalies, that's usually when we start thinking about overgrowth syndromes. The one I'll talk about today is the PIK3CA related overgrowth syndromes. The only vascular malformation that doesn't fit nicely with a primary vessel is something we call FAVA, or a fibroadipose vascular anomaly. We'll broach that as well. When you go through old textbooks, you might also see things under the vascular malformation heading, like syndromes like CLAPO or NCAP. These are now under the umbrella of PIK3CA overgrowth, and we'll review that as well. As far as vascular malformations, I did touch upon this, but sometimes it's easier to see in graph form. Vascular malformations are present at birth, although you might not see them clinically or patients might be aware of them. And then they'll grow with the patient over time. And around puberty, they usually exponentially grow quite a bit, as opposed to things like hemangiomas, where we counsel patients on early exponential growth phase, plateau phase, and involution. Vascular malformations are going to be something patients are going to live with for their entire life. So depending on when patients present with a vascular lesion, you might be thinking it could be a deep infantile hemangioma, but if the patient's presenting later on in adolescence, that doesn't really fit the picture, and you should start racking your brain for other differentials like vascular malformation. So these are all the vascular malformations we'll talk about today. When it comes to vascular malformations, for the longest time in literature, everything was phenotypically based. What I mean by that is everything was grouped based on their presentation, and then we would clump them together into studies and cohorts and see what responded great to treatment. We're now getting the advent of more genetic analysis for these vascular anomalies, which is great because it's now allowing us to try new targeted medications. Typically, when we talk about genetic etiology for these vascular malformations, it is a mixed bag. What I mean by that, it's a little bit blurry. You are getting one primary driver mutation, but thereafter you're getting some other secondary changes. Typically, the main driver mutation in slow flow malformations, meaning venous malformations or lymphatic malformations, tend to involve the PIK3CA pathway. So venous malformations, tend to harbor TIE2 or TEC mutations, as opposed to fast flow malformations like arteriovenous malformations tend to harbor mutations in the RAS-MAP kinase pathways, such as RAS-A1 and CMAVM1 syndrome. And then in terms of capillary malformations, they tend to harbor G protein mutations. So the classic example is a GNAC mutation in a port wine stain. But we also know that GNA11 is a driver for larger, broader, reticular, or geometric capillary malformations on the body. So lymphatic malformations, when they walk into your office, can be a little bit scary. The larger lymphatic malformations we tend to see usually are located on the head and neck or the upper thorax. Sometimes they can be so large they even get referred to us prenatally, and they get picked up in OB ultrasounds. Typically, the child is healthy, is doing well, but they'll have this large growth that they come into clinic with. Typically, when you palpate them, I like to refer to it as almost like a wet sponge under the skin or a water balloon under the skin. As you palpate, it'll be soft and it'll almost mold to your hand as you palpate the area. They typically don't cause any acute distress. However, when they're located on the head and neck, one of the classic history items that parents will give you is it occasionally swell or get red when their child has a respiratory illness. Remember, lymphatics are important for white blood cell monitoring for infections. So as a result, they have a lot of white blood cell flow and are at risk for infections, especially on the neck. So sometimes you'll present as red, swollen, and warm, or sometimes after trauma, since lymphatics are one cell vessels, they're really prone to mild trauma leading to bleeding, and sometimes they'll present as red and firm too. So keep that in your mind if they're presenting in one of these acute phases. When they're on the head and neck and they present to your office or present to our vascular lesions clinic, I should say, the other thing we address too at a young age is to make sure it's not interfering with eating or it's not interfering with breathing as well. So one of the important workups for lymphatic malformations will be imaging as well. Other examples of lymphatic malformations, you can see on the left, this is a deep lymphatic malformation involving the left thorax and axilla. And then the other two photos are more superficial lymphatic malformations. So this is what the textbook refers to as that frog spawn or frog egg appearance, where it almost looks glassy and fluid filled. These are superficial lymphatic malformations. Sometimes you'll see these superficial blebs on top of the deep blebs as well. Depending if a child only has deep versus superficial will dictate our therapy as well as what kind of symptoms they're experiencing. So right away, when you're looking at a lymphatic malformation and you're palpating it and you're getting the clinical history, you usually have a high index of suspicion. You can usually confirm your suspicion with ultrasound. Ultrasound, especially in pediatrics, is great. It's quick, it's non-invasive, and no sedation is needed. And it will not only confirm the diagnosis for you, but it'll also easily refer if the lymphatic malformation is mainly consisting of small cysts or large cysts. And that's important for intervention when we talk about interventional radiology intervention. But in kids who have larger lymphatic malformations, especially like on the head and neck, and you're evaluating for alimentary interference or airway interference, we'll get MRIs with contrast for these kids. Some additional tidbits about lymphatic malformations. We talked about what it feels like. We talked about that they're fragile. And we talked about they typically can get infected. So sometimes if kids are having multiple infections, we'll actually put patients on prophylactic antibiotics as opposed to just episodic courses of antibiotics. For therapy for lymphatic malformations, if it's a superficial lymphatic malformation and it's not bothering the patient for pain or bruising or due to cosmesis, you can leave it alone. But if it is bothering the patient for any of those reasons, usually what I'll do is I'll treat with ablative CO2 laser to scar those areas down, or I'll treat with topical sirolimus. Sometimes I'll do topical sirolimus in addition to other avenues, especially local excision. So sometimes when patients come in with superficial lymphatic malformations, I can't evaluate to the extent of where that mutation takes place. So I do tell patients that there's a high risk of recurrence after excision. Sometimes patients, though, still want that option. So after excision, I'll offer them topical sirolimus as a means for prevention of recurrence. For larger or more symptomatic lymphatic malformations, this is really where our colleagues in interventional radiology come into play. For the macrocystic lymphatic malformations, they respond wonderfully to sclerotherapy. The reason is think of a lymphatic malformation as a large sponge, like I said before, and it has multiple pockets, each filled with lymphatic fluid. So for the large cyst, it's very easy to get in there with a needle and introduce a sclerotherapy agent. Sorry, Halloween trick-or-treaters. And once you put in the agent, either doxycycline or bleomycin, what it does is cause the inside of those lymphatic vessels to get sticky and close down. So patients don't have as much swelling and as much pain or bruising into those pockets. So sclerotherapy is a great option for macrocystic lymphatic malformations. For microcystic lymphatic malformations, there's not large cysts to target with sclerotherapy. So for these patients, what we wind up doing is usually systemic sirolimus as well as compression, depending on the location. These are images, of both microcystic lymphatic changes and macrocystic changes. So on the left are ultrasound photos. When you put an ultrasound on a microcystic lymphatic malformation, you really don't see much. You'll see small little pockets, but the thin septae really compress on each other once you put the ultrasound probe on it. So all you really see is soft tissue. And when you put the probe on Doppler, you won't see any other vascular malformation. So you shouldn't see any high flow for any arterial or slow flow for any venous involvement. Middle photo shows macrocystic ultrasound changes. This is what I was talking about with large targets to go after with sclerotherapy, which is typically doxycycline or bleomycin in our experience at our vascular anomalies clinic. On the right is an MRI image. I am no radiologist, but the nice part about lymphatic fluid is it lights up on T2 weighted imaging, so it's really easy to pick up, and it's easy to compare it to blood. So sometimes blood can also light up on these T2 images, but if you compare it to T1 images, you can rule it out. So more anterior here, you're looking at the upper neck. More anterior is more macrocystic changes where it's brighter, and you're looking at more microcystic changes, more dorsal. Venous malformations, the best way to think about venous malformations is to think about them as varices. Right, varices are just large dilated veins. When we talk about venous malformation, you're having large dilated veins that are anomalous, that shouldn't be there. Typically, these will present later as well, depending if they're more deep, rather than superficial. So, for example, the picture on the right is a deep venous malformation on the medial knee. This might not cause any issues unless the patient's really active and really athletic. And when they first present to your office, you might have a broad vascular tumor differential. You're going to have to rely on MRI to make that diagnosis. But when it's more superficial, the diagnosis can be easily made in clinic. For example, on the dorsal hand here, you can obviously make out the venous abnormalities on the dorsal hand. And another good way to actually know if it's a venous malformation is, other than using visual perspective, what I like to do in clinic too is use gravity to your advantage, right? So varices dilate with gravity. So if it's on their hand, I'll have them put their hand down by their ankle, and you'll see those varices dilate. And then when you have them raise the hand above their head, those varices drain. So that's how you know these are veins, and then you're dealing with a venous malformation. The medial photo is actually status post sclerotherapy. So the main approach for treating venous malformations is to get those vessels to compress down. So you either do that through sclerotherapy or compression. And this is a great response to sclerotherapy in the middle photo. Venous malformations can occur anywhere on the body. They also like to occur on mucosal surfaces. So quite often we see venous malformations in the mouth, commonly on the tongue, or on the floor of the tongue. And classically, we can also see them intraorbit as well. And those tend to be complicated cases to manage. So once you're seeing a venous malformation in clinic, and you have suspicion, or to confirm it with imaging, you can use ultrasound, but most of the time MRI is your best treatment of choice, because you want to see the extent of the venous malformation, and you also want to see if it has any connection to any large caliber veins, which is really important before you treat with sclerotherapy. Tidbits for venous malformation that we broached already. We talked about clinical exam. We talked about how deeper venous malformations can be confused for deep infantile hemangiomas, especially when presenting in children, and how you'll have to use imaging to delineate the two. And then we also talked about how around the time of puberty, especially in muscle, they can cause a lot of pain, especially in active individuals. The last thing I didn't mention is that's important with venous malformations is you have to remember these veins are not normal veins. They're large, they lack the valves, and they don't have the normal typical laminar blood flow we like to think of in normal veins. As a result, you're getting eddies and abnormal blood flow in these vessels. So when these vessels expand, you're getting more and more eddies, and what it winds up leading to is a lot of inflammation in the inner vessel, and that leads to things like thrombophlebitis, so inflammation in your blood vessel, little clots. So another clue to venous malformation is sometimes patients will tell you that every once in a while I feel these firm pebbles within the venous malformation, and that's when it is exquisitely tender. So that's another clue that a patient has a venous malformation, and those little individual episodes are episodes of thrombophlebitis. As far as therapy, if the venous malformation is asymptomatic, meaning it's there and you notice it and it swells a little bit during activity, but it's not causing pain and it's not limiting function, you don't have to treat them. And in many cases, we don't. They will leave our clinic with a compression garment, just like varices on the lower leg that you get with time. Compression is the number one treatment choice. If those varices can't dilate, you're less likely to have symptoms of pain. So in addition to compression, if they're having symptomatic disease, if they're having multiple episodes of thrombophlebitis, we'll give them episodic NSAIDs. Sometimes if patients are having a lot of pain, that's usually when we advance therapy and talk about sclerotherapy. Trick-or-treaters, sorry. And venous malformations respond beautifully to sclerotherapy. So these patients usually undergo multiple episodes of sclerotherapy and get quite well. The last option for venous malformations is excision. So when venous malformations are small, specifically, I won't address them today, but there's certain small venous malformations, like what we call GVMs or blue rubber bleb syndrome. Those are when you have small venous malformations. Those can be easily excised. So although we don't typically think of excision as a treatment for large venous malformations, for small venous malformations, it is an option. This is just further imaging of that intramuscular venous malformation. I'd shown a picture previously in her knee. This one's actually within the gastrocnemius. And the reason I pointed this out to is sometimes on imaging, if you're not sure if it's a venous malformation, one of the tidbits we use to make sure it is a venous malformation is you'll often see these little blood thrombotic levels. So here on the right side of the right photo, you'll actually see a little bit of thrombus within that vessel. And that clues you into these are veins. Sometimes we also see combined malformations. So nothing in medicine is clear-cut, right? And a lot of the genetic pathways overlap. So sometimes we'll see patients present with both combined venous and lymphatic malformations. And in cases like this, you'll use all the modalities of treatment that we had talked about. So for these patients, they'll walk away with compression, they'll walk away with a plan for sclerotherapy, and they'll also walk away with a plan for medical therapy with sirolimus. Sirolimus is kind of the old faithful therapy. We tend to use sirolimus for really complex vascular malformations, ones that are not easily treated with just sclerotherapy or just compression or just surgery. Medicine has been around for a long time, and we know its side effects and how to monitor and how to dose it very well. So it's an mTOR inhibitor. I'll show you the biochemical pathway a couple more times to refresh you. And the dosage is titrated to a target serum goal. So patients often need multiple blood sticks to make sure the dose is where it needs to be. And we usually tell patients it's slow to work. So it's going to work over 6 to 9 months. So as you're waiting for sirolimus to kick in, these patients are often undergoing sclerotherapy sessions in the interim. The goal for sirolimus is to decrease volume of the vascular malformation as well as to give patients pain relief, right? We're not talking about curing their disease, but we're talking about improving their quality of life. And then the other goal is with sirolimus is to improve coagulopathy. Sometimes when you have these large vascular malformations, they have some consumptive changes, so sirolimus can help with that. Typically, if a patient's pre-pubertal, we'll usually keep them on the medicine for a few years and then pull back. And then what we'll do, what I mean by pull back is stop. And then around the time of puberty, if the vascular malformation has grown quite a bit, we'll start them back on sirolimus. Most of the time, the medication is well tolerated. The common side effects we see in patients are things like stomatitis of the mouth, some mild fatigue, some mild GI upset. And when we're doing lab monitoring for dose titration or just serum level monitoring, I should say, we're also looking for things like dyslipidemia, mild cytopenias, and mild LFT elevations. Moving on to capillary malformations, I think most are familiar with the classic presentation of a capillary malformation on the face, also known as a port wine stain. I think most dermatologists are well versed on the risk for Sturge-Weber, especially when it's in the V1 origin and when it's bilateral. But typically the capillary malformations that walk into our vascular anomalies clinic are much more extensive and much more broad. And the ones that usually walk into our office are the ones you see on the right. These are what we refer to as reticular capillary malformations, where it almost looks sieve-like or net-like, or these larger geometric capillary malformations, which you see on the right in the A image. These capillary malformations usually scare pediatricians, they scare parents. When parents come in, they need a lot of reassurance. And usually to the pediatric dermatologist or the astute vascular lesion clinician is they're thinking about other things that could be associated with this. So when you have larger capillary malformations like this, you need to look at other parts of the body. You need to look at head circumference. You need to look at limb length. You need to look at limb circumference. And you need to be, at your follow-up visits, be really aware of possible overgrowth. Capillary malformations that are reticular or geometric can be associated with limb hypertrophy or macrocephaly, or you might be looking at the tip of an iceberg for an overgrowth syndrome. We've gotten much better in determining some of the genetic etiologies for these capillary malformations, but unfortunately, the genotype-phenotype correlation doesn't always match. So even though we do, or I encourage gene testing on these early broad capillary malformations, a lot of what we still do is clinical monitoring. As far as treatment for capillary malformations, these are a little bit different from the previous ones. So when we talk about venous malformations and lymphatic malformations, and we're talking about surgical interventions and compression, for your typical capillary malformations, typically we might not intervene at all. Or if patients are bothered by it, we can treat it with a vascular laser like V-beam. I bring these photos up just to talk about the genotype-phenotype correlation. Not everything is perfect. And the reason I say not everything is perfect is because these are all phenotypic appearances of a PIK3CA gene change. So in a second, we'll review PIK3CA overgrowth syndromes. Depending where that PIK3CA gene mutation is, whether it's early or late, whether it's in a certain tissue or not a certain tissue, whether it's in a progenitor cell, whether there's epigenetic changes in the patient, it can have multiple different phenotypes. So for example, on the left, this is an example of Klippel-Trenaunay syndrome, This is when a patient has ipsilateral capillary malformation, venous malformation, and limb overgrowth. And then on the right, this is an example of a FAVA, or a fibroadipose vascular anomaly. FAVAs are when the normal muscle parenchyma is replaced by fatty vascular tissue. They're quite painful, quite challenging to treat. And they're both secondary to PIK3CA gene changes. So that's where our knowledge of genotype-phenotype is a little bit short. We're getting better, but we're not quite there yet. So these are classic examples of a PIK3CA overgrowth patient. On the top left, you'll see large lipomatous overgrowth. You'll see deep venous malformation, superficial capillary malformation. On the foot, you'll see macroglossia or enlarged toes. Bottom right is another patient. This patient happens to have a large capillary malformation on the upper arm, lower arm, and upper chest, as well as macrocephaly, as well as syndactyly. These are all possible presentations of PIK3CA overgrowth. Historically, we used to refer to these as CLOVES or MCAP or Clapo syndrome. Now they're just under the one umbrella. So this is where the genetics has been helpful in some management of the patients. But again, it works much better retrospectively as you're following the patient clinically. So things to look out for. In these PIK3CA overgrowth patients, you'll have lipomatous overgrowth, you'll have presence of vascular malformation, you'll have some epidermal changes like epidermal nevi, they'll have skeletal changes like leg length discrepancy as well as scoliosis, excuse me. And the overgrowth can also affect tissues you wouldn't normally think of, like brain parenchyma, that can lead to parenchymal crowding, seizures, and intellectual disability. Patients also often have endocrine abnormalities, so we usually do lab workup for these patients, checking their thyroid function. Additional tidbits, these PIK3CA overgrowth patients are very complicated to manage, so they're usually always managed in a vascular lesions clinic. If they have their vascular malformations, excuse me, are usually targeted, as we had talked about previously, with both compression, sclerotherapy, as well as medical management. For the longest time, we managed these patients with sirolimus, but we now have other medicines such as alpelisib, which I'll mention here shortly, which has been a game changer. Patients with overgrowth are also at slightly higher risk for some tumors. The big one we worry about is Wilms tumor. So these patients undergo serial ultrasound screening. They're also higher risk for coagulopathies. If they do have any musculoskeletal changes like limb asymmetry, scoliosis, or gait problems, they also follow with ortho. And if they do have macrocephaly, they usually get referred to neurology to also monitor for any parenchymal changes. So I know the biochem is confusing and it's a bit of a lot, but as far as the PI3 overgrowth syndromes, we now have, the reason I'm showing this is because sirolimus, historically, which you use for these overgrowth syndromes, is a downstream target. So it works, but doesn't work as well as some of these more targeted upstream drugs. So we're really excited about the advent of new medications. Specifically, the one we use presently is called alpelisib, which actually targets the kinase, the PI3 kinase. So alpelisib has now been used for the past few years for the PIK3 overgrowth patients, slowly getting used for venous malformations too, but mostly for the overgrowth. It gained temporary FDA approval out of compassionate use from a small retrospective cohort study. Most of those were children, which is great for my practice as a pediatric dermatologist. The data was pretty impressive. At week 24, since it's retrospective, they didn't have before and post imaging on all the patients, but they noticed out 30% of the patients who did have imaging had more than 20% volume reduction, and about 3/4 of patients that had some form of volume reduction. But some of the exciting things they were able to show were great improvement in patient quality of life outcomes, things like fatigue, overall perception of the vascular malformation, functional improvement, patient-perceived limb asymmetry, tissue hypertrophy, and pain. They saw great reductions in these. So right now, the EPIC P2 trial is ongoing, which is a randomized placebo-controlled trial. So that'll give us more accurate data. But what we're seeing clinically is good results. So I could say we have about a handful of patients on it. They're doing great, and we're seeing good results. I know it's always not biased, but a little short-sighted when you look at case reports. But when we have so few patients, we have to rely on case reports sometimes for these rarer diagnoses. And this is an example of a kiddo who at 9 months had considerable complications through PIK3CA overgrowth. So you'll see on the top left considerable tissue hypertrophy and inundation of blood flow in that right leg, leading to gait abnormalities, repetitive cases of sepsis, and a lot of consumptive coagulopathy. At age 9 months, they were put on alpelisib. A year later, you can see drastic changes in that limb. So it doesn't look as inundated with blood flow. The tissue is not as hypertrophic. And most importantly, there were also improvements in consumptive coagulopathy and rate of infection in this patient. So at 12 months, they're actually able to get the patient off warfarin. And the patient was able to recapture growth curves. So the hope now is with early targeted therapy that these patients will actually be able to recapture their growth curves and have normal development. But the jury's still out on when the right time to start these new targeted therapies is and how long to keep them on it. So I'm really hopeful, and hopefully 5, 10 years from now, you even have better data, and this will be more mainstream application. Um, as far as safety profile for alpelisib, the safety profile is actually somewhat comparable to sirolimus. We don't see too many side effects. Most commonly, we see diarrhea, aphthous ulcers, or dehydration and pain. So dehydration and hyperglycemia are the two that stand out compared to sirolimus. Um, we monitor glucose levels in patients on alpelisib quite closely. If they're hyperglycemic due to insulin, it actually counteracts how the alpelisib works. So glucose management in these patients is really important to achieve efficacy. And then as far as laboratory abnormalities, we don't see it too frequently, but sometimes you can see mild decreases in white blood cell count and red blood cell count. And then we monitor for LFT abnormalities. The last vascular malformation we'll talk about is AVMs. These are classic presentations of AVMs. Sometimes AVMs can fool you because they can just look like simple capillary malformations. The classic examples are ones we see with as patients get older. Due to the enhanced blood flow in that area, they usually have some hypertrophy of the tissue there. So on the left, you can see the tissue hypertrophy on the forehead, and on the right, you can see the tissue hypertrophy on the lower lip. But the difference is capillary malformations don't blanch as well as capillary malformations. You can blanch out the blood flow of a capillary malformation, and it will refill, but it refills much slower compared to an AVM. AVMs also tend to be a little bit more warmer to palpation, and sometimes you can feel a palpable thrill. As far as diagnosis for this, ultrasound I find to be less helpful. Usually MRI is the diagnosis of choice. These AVMs usually are primarily managed by our interventional radiology colleagues, and they're usually managed through embolization. Sometimes if they're quite large, we'll send them to our cardiology colleagues to make sure there's no signs of high output cardiac failure via echo. But the most important thing I find for dermatologists is be on the lookout for small AVMs that mimic capillary malformations. So over the past few years, we've gotten really good at characterizing CMAVM syndrome. So this is when patients present with more reddish brown vascular patches, so more brown than you would expect for typical capillary malformation. And the telltale sign is patients will say they've gotten more with time. So when they present to you, they'll have multiple. And when you palpate these, they'll fill more rapidly, they'll feel more warm. And it's just a little bit more unusual than the typical capillary malformations you'll see, which are just large geometric or large reticular or located on the face. So if you see this on a patient, have a high index of suspicion for CMAVM syndrome. And the reason I say I have a high index of suspicion is it's more common than you think. And these patients are at higher risk of AVMs in the brain and spinal cord and require screening. So you can make a huge difference in these patients. Sometimes you might also see beer spots in these patients, or you might also see tiny AVMs on the lip, on the mucosal lip, which might confuse you for a Osler-Weber-Rendu or HHT differential. But then when you look at the rest of the skin, you'll see these red-brown AVMs mimicking capillary malformations. And that concludes our whirlwind tour of vascular malformations. I know that was a lot, but I hope this helped conceptualize vascular malformations for you all, organize it a little bit better, introduce you to how we manage these, as well as some new targeted therapies we have. Thanks for your time.
Oh my goodness. That was amazing. Amazing. You did a great job. That is a tough subject to get through. And the tidbits you shared are golden little pearls, golden little nuggets.
Good, I'm glad. It's such a broad topic and it can be really complicated and hard to conceptualize. So I'm hoping through at least a couple of those ways that makes it a little bit easier to organize for the residents and some of the practitioners.
Yeah, that was amazing. And you know what? I practiced pediderm for 20 years and nobody ever told me that a lymphatic malformation felt like a wet sponge, but that is exactly what it feels like. When you said that, I was like, oh my gosh, how come I've never heard that? but that's it. Like that's perfect. And yeah, just those little pebbles you talked about in the venous malformations, that's just a great clinical sign in that pain. And yeah, so many good little nuggets of information that people can take away. And then certainly the residents, so much good board fodder, right? That can come from this now with all the genetic pathways. And it's great because like you said, it's defining some therapies now where before, we have the old faithful that has done a great job for so long, but to have targeted therapy, I mean, yeah. And again, I've never seen one of the PIK3CAs in person before, only in pictures. But yeah, I mean, just the treatment options, because before those poor kids were just miserable. Some didn't survive. I mean, it was just, it's what we are learning, even in the recent past, has been a game changer for this field. And, you know, it's great.
I agree. I'm really excited. So in the rest of peds derm, we're getting so many new pharmaceutical interventions, but especially those PIK3CA overgrowth kiddos. Hopefully, in the next few years, we'll even have more data on when to start therapy and see if we can really curb some of those changes. Because previously,
Right.
the conversation with patients and families was so challenging. And don't get me wrong, it still is challenging, but previously it was okay, we think this is what it is. We'll do the genetic testing, and then we'll wait and see and treat things as they develop. Um,
Right.
so if patients weren't having symptoms, it's sometimes challenging to tell parents to say, okay, we're gonna wait and see and then start sirolimus after this becomes more impactful in terms of quality of life. But I'm hopeful we'll have better data where we can say, you know what, we know if we start alpelisib at age one and these overgrowth, we can stop a lot of these things we were seeing before and curb infection rates, curb coagulopathy rates, and give kiddos a better quality of life. And that's what I'm most excited for.
Yeah, yeah, so true. It's an exciting field. And again, I just got back from Pedra too. And, just in the last 12 years, just that has developed so much. And again, it's moving forward. Peds derm is just it's always been an amazing field, but I feel like every day it gets more amazing. And just all the great minds that are now in it. We have the giant shoulders that we're standing on and some of these people that even just defined what hemangioma was, right? And now it's just moved so much past it. Yeah. And then the other tip that you gave too, that I actually was one of my very first cases when I was an attending. So graduated, right? Now I'm an attending a peds derm, get called to the ER. And this kiddo just had this kind of lump of swelling here. And had a URI and it came up kind of in the central chest, but it didn't have any discoloration over it. And I'm like, oh gosh, what is this? And of course I'm like, well, we can ultrasound it, but I'm like, don't just be that person that jumps to the diagnostic test. Like think this through, right? And
Agreed.
I just sat in the room and talked to the parents and watched her play. And I think that's a good tip for, you know, somebody that doesn't see peds a lot, you don't always have to throw them up on the table and examine them. Like just sit back and kind of watch, And while I was watching her just kind of play, I noticed that she had kind of just a blue blush on her fingers and that her hand was subtly bigger. And I was like, oh my gosh, this is a lymphatic malformation. It's swollen. She had, this upper respiratory. And again, it was just, and when I walked in, I had no idea. And I was just like, oh, we just need to get imaging. But then I was like, no, don't just say we need to get imaging. Like think through it and just watch. And it's amazing what you can pick up on if you just let the kid play in their own environment, because when they get upset, then you can't really examine them anyway. And that, then again, you notice those subtle changes because they're not trying to hide them from you when you're actually trying to examine them. Yeah.
And you know what too, like dermatology is such a visual field. We're so used to not quite a door diagnosis, but maybe like a 30-second diagnosis when you see something clinically. But when it comes to these vascular malformations, and if it's not quite as obvious, sometimes the history is just super helpful when they're saying it's been there for a long time, it's grown with them, they're having these episodic swelling or pain episodes. I'm feeling that rock pebble in the venous malformation, or got red and swollen when she had a cough and URI symptoms. And then hits you like that, you're like, oh, this makes sense now.
Yeah. This totally makes sense. Yeah. And she ended up, hers didn't get swollen. It went down after the URI and it was asymptomatic. So we didn't do anything with it. Now, that was years ago. But yeah, it's funny how sometimes, yeah, when it just hits you. And the history is important in these. And I know a lot of derms, just like you said, want to make a quick diagnosis. They don't even want to hear the history. Like, don't give me the history. It's just going to, you're going to give me a bunch of red herrings, right? But it really does help. It really does help. So, again, great lecture, Dr. Grove. I'm so glad that you ran into me in my life and that I was able to draw you into T4 because what you gave was just so perfect. I know it's going to help residents and then ultimately help patients, which is the whole goal of this. So thank you. Keep doing the amazing and awesome work that you do every day on behalf of our patients. And thank you for taking Halloween to spend with us and share this great information. So thank you, thank you, thank you. And I'll buy you a drink next time I see you. I promise and cross my heart.
Sounds like a plan.
All right. Happy Halloween, y'all. Be safe.
Bye, everyone.
Bye-bye.